So we have Kumar here and Madison Ward Willis, and they're going to give us an update on what's going on with the Chi-Squared program that has been in the works for a good while. And so I'm going to just turn it over to you, Jay.
Thanks so much. And we have some slides, so I'll definitely make sure to share that. And, over the past really 18 months, we've been doing a lot of legwork and a lot of planning with our partners in South Carolina and with the Duke Endowment to really help understand how we can best position the Carolinas Health Innovation Institute to support and accelerate work. And through that, have had some wonderful conversations with John and Laura, who I see from Transitions, David and Catherine, partners in South Carolina, Ken Deans, to really get a sense of, given the landscape of serious illness care and the amazing work that this group and others are doing, where can the Institute best put our resources to help advance the work in a meaningful way? And so through that, we've done a lot of background work. Really grateful. I see Sue Collier and Karen Reeves, who were instrumental in building the background and kind of our understanding of this topic. And I want to be clear that as we go about our work with the Institute, there are three distinct phases in which we work. First, it's around cultivation. And for us, that means understanding a topic through meaningful engagement with partners. We don't want to show up and be an expert in any one space. We want to be collaborative and want to figure out, how do we do this together? How do we take what's out there and help advance it and accelerate it? How do we use the information and the expertise in the field across both North and South Carolina to advance work that's important to all? And so that cultivation phase is critical. And that's the phase we've been in for the last 18 months, which is where we need to do the good, deep work internally to get a sense and a level setting of understanding so that we can show up to these conversations with a level of humility and appreciation for all the work that you've done. And so that's why we've been a little bit quiet. It's that cultivation period that we've been in. Now we're moving into our co-design phase, and that's really more of our outward facing. How do we identify the right partners? Who are the right partners? And what do we need to design together in order to advance the work? And so through that, we have a 7-step innovation process that ends in systems change, but the point of our work is not to get to step 7. The point is to look back after a certain amount of time and see, has the system changed for the better? And so that may be iterative, that may force us to go forward, backwards, back forward, whatever it takes to move the ball a little bit more towards the type of care that people want. And then ultimately, from cultivation to co-design, we go to catalyzing change. And so for us, that is, what are the policy barriers? What are the regulatory or payment barriers that need to be considered? And how do we help leverage the resources of the North Carolina Healthcare Association, the South Carolina Hospital Association, and the Duke Endowment to advance collectively the work meaningfully? So that's kind of our, at a 30,000 foot level, the basic way in which we operate. Again, cultivation, where we've been for the last 18 months, we're emerging from our cocoon, I guess, a little bit to talk about how do we co-design some opportunities. Where are there opportunities for us to really play? I think there's a variety of disease states, and we'll talk a little bit about the things we've learned and how we anticipate that really coming to bear, and where this group, in conversations with David and Catherine, has a real opportunity to influence and provide input and insight in a meaningful way. And then I want time for you all to ask us and questions, hard questions that we may not have the answers to right now, but will force us to go back and reconsider certain things. But then also, what's the best way as we go through our design process to ensure that this group and other stakeholders that may not be present today are involved and informed in this work? And so I'll stop there and I'll turn it over to my colleague, Madison Ward Willis, to really give you a little bit of our cultivation period and what we've learned. And then I'll jump back to kind of talk a little bit more about the Institute and our next steps. So Madison?
Yeah, good morning, everyone. So I just want to start by sharing a little bit about, as Jay mentioned, the cultivation phase that we have just kind of wrapped up, and share these two documents with you. So in 2020, we formed a serious illness working group, and that was between both state associations, as Jay mentioned, led by Sue Collier and Karen Reeves, to really help us do that landscape analysis across the Carolinas and understand the work that was happening. So, we talked to over 150 stakeholders last year, many of you on this call, and really wanted to learn about the current state, what existing barriers are, what are those innovative solutions that are happening, and then other opportunities for improvement. So as you can see on the left, this is just the 2020 work group report. This is available on our website. And really, what we learned is that patient voice must be at the center. Serious illness care, as you all know, is a complex topic. Many stakeholders want to be involved in the future of innovation. There's an opportunity to increase awareness and collaboration among all serious illness stakeholders. And then the future efforts must focus on improving outcomes, lowering cost, and reducing disparities. And on the right side of the screen, you'll see a patient journey map that we did. And it was an incredible process. This is also on our website, available for you to view. And this really has informed the work that we will be doing in the coming months as we move into that co-design phase. Jay's going to talk more kind of about how we will continue to engage subject matter experts, including patients, into our work. But this just kind of gives you a glance at some of the work that we did last year.
Great. Thank you so much, Madison. And if you want to leave it on the, if you want to go back right there. And as we think about that patient journey map and the work that Sue, Madison, others had done, that really has grounded our work. And these are things that you all as a coalition have known. And it's important to acknowledge that and for us to really lean on the things that we gleaned from you all. And so what we're sharing today is stuff that y'all already know. This isn't revolutionary. This isn't, something that we came up with independently and think we're some sort of genius for figuring out, hey, we need to keep patients at the center of serious illness care and their families. Now, these are things that are real and that have been a grounding part of how we're trying to approach this work. So next slide, please. And to the point, these slides, everything on here is on our website. So the best way to get access to this stuff is go to the website. I put it in the chat, ncha.org/CHII. And so you'll be able to download the patient journey map and the caregiver, and the work group report, so that you'll be able to see those in more detail. So again, I just wanted to give you a quick snapshot of our organizational governance. It's a little bit complicated, but we have two state teams, one in North Carolina and one in South Carolina. Those state teams really are on the ground coaches. They're right now working with communities on a variety of topics, from access to care, not just serious illness care, but really, low income uninsured care, community-based coalitions for health. We're working with health systems in both states around how do they implement hospital at home programs, which hospital at home is not home health. It is, we are defining it using the CMS waiver, which is acute level care that is leveled by an ED or an inpatient setting that can be delivered in the patient's home. So we're working on how do we get that CMS waiver more expanded? How do we get it sustained? What does that look like in the post-PHE period, our public health emergency period? So those are things that are happening at the state level. Then each of our three organizations form a joint operating agreement. So we're operating formally as a shared organization. Right now, we are recruiting for an advisory board for that institute, made up of experts from not only North and South Carolina, but across the country. that are not just in serious illness care, but really thought leaders and influencers that can help us figure out where should we be focusing our energy, how can we, when new topics emerge, where does it make sense for us to play? And then ultimately below that, you see the central team. Central team is our staff, myself. I'm our senior director of program design. We have Julia Wacker, who's our interim executive director, Dr. LaPonda Edmondson, who is our senior director for evaluation. We have Jill Armbruster. She's based out of Columbia, South Carolina. She is our senior director of communications. And then below that, we have a design team, a evaluation team that are working to figure out how do we answer these hard questions and how do we kind of take these pieces of information and snap them together with metrics that help us move the ball forward in our areas of focus. And one of our first areas of focus that we see an opportunity in is obviously serious illness care. And next slide, please. And over the last 2 years, really, we've done a lot of, we've had a lot of conversations. We've had a lot of insights and conversations with payers in particular that have helped shape our kind of place where we are. And so what we kind of realize is there are 4 major areas of focus within serious illness care. There are the conversations, there's the care delivery from generalized to specialized medicine. So how do we go from palliative to hospice or respite care? And then there is a case management support, and then family and caregiver support. Deb, we're actually partnering with Ariadne Labs right now. We're in the process of getting finalizing an MOU with them to help us in a variety of spaces, including our hospital at home work, and then with serious illness care, really looking at how do we, with partners in South Carolina, they've done some independent work with some of the health systems down there. So how do we aggregate that information and bring this holistic level of care together? So yeah, Ariadne Labs is definitely one of our early partners that we'll be working with and have been working with closely. Atul is no longer with Ariadne Labs. Actually, he when the Amazon Berkshire Hathaway merger happened, he went to lead that, and so they have new leadership there, but still engaged and have had some good conversations. With that, what we're trying to do ultimately, and what we think is solutions where the Institute can play a huge role, should be focused on developing new payment strategies that support comprehensive care models that can deliver goal concordant care for serious illness patients and their families. And what that looks like is we know there are a lot of places where the conversations are happening really, really well, or the case management is happening really, really well, or the care transitions are happening really, really well, or the family and caregiver supports are happening really, really well. Where we're seeing gaps, and what we've heard from payers and from our provider community is that there are very few places where all of that is happening seamlessly and is being paid for continuously. And so what we've gathered is through, as we move into Medicaid managed care, as we move into various shared savings opportunities, is how do we as the Institute create an environment for payers and providers to have an opportunity to identify the shared savings and shared risk required in order to manage a specific patient population? What are the guidelines for effective reimbursement, and how do we ensure that those guidelines are applied in practice so that the ultimate full continuum of care from the diagnosis to end of life has a payment mechanism that's holistic? And what that looks like in the way we're going about it is, right now, this is what we have, and we are in the process of recruiting a topic action team, which will be about 5 to 7 individuals from North and South Carolina to help us on one side. When we say mental health supports, or you see these diamonds, what are the elements that need to be included from a care delivery and patient experience standpoint. And then on the flip side, from a payer standpoint, what are the guidelines for effective reimbursement? And so together, our topic action team, along with the payers and our managed care committee, are going to create a pilotable opportunity where the Institute will be working with both payers and providers to test this model and underwrite the risk period to figure out what is the shared savings opportunity. We know we can't do this for serious illness care because it's just too broad. And so the first step that we're trying to figure out is, what is the specific disease state and population that would warrant us focusing time, energy, and effort to figure out this underlying model of care? And then if it works for one disease state, how do we expand it to other populations? That's where we're at, is really in that recruitment of that topic action team, because we really want the experts across the Carolinas to, one, tell us who the patients we should be focusing in are. So we've done some initial analysis through our claims warehouse to look at cancer, heart disease, COPD, and other respiratory illnesses, dementias, renal disease, and liver failure to see what the utilization rates are in North Carolina. We're getting that information for South Carolina as well, and then are looking at that across a map to see where in the health systems these populations are emerging. Where are they being overutilized? Where are they being underutilized? Looking at it from a pre-COVID and over the last year, what are those opportunities? And then figuring out where we can then test this in a meaningful way. And I think that's kind of the place we're at. So recruiting that topic action team to help us figure out what the population is, help us put some meat around the bones of what are the elements of the care model that should be tested. And then we have a payer finance group of healthcare finance experts to say, once that model of care is designed, these are the guidelines for effective reimbursement. That's our goal between now and the end of 2021, is to get to a place where we have the guidelines for effective reimbursement to release some sort of RFP or some sort of targeted opportunity to test and pilot in 2022.
Okay. Hey, Jay, can I interrupt you for just a second? We've got a couple of questions, and I wonder if it would be appropriate to just stop and address a couple of questions so that we can move on.
Absolutely. Absolutely. I see Tim's hands raised.
Yeah, Tim. So Tim, go ahead. And then there's one from Henry Ward on chat as well.
I was actually furiously typing you a message. This is fantastic. Two things. One's home health and one's hospice and palliative care. Let me go to hospice and palliative care. Yeah. We, Jay, I serve on NCHA's Strategic Partners Board. So we would offer any assistance in the EOL and hospice and palliative care, since 98% of the hospices are members in North Carolina, and we are South Carolina Home Care and Hospice. Yeah. So we're here to help. We're here to offer assistance. We've got a broad variety of experts to do in those types of conversations and data. 47,000 patients were on service in hospice in North Carolina last year, and we got the data that were on service in South Carolina. You probably can draw that too from the SHIC. Getting back to hospital at home and home health. Yeah. What you said was exactly true. However, in terms of the Medicare waivers, I do want to emphasize one thing. The Duke hospital model is using Duke Home Care and Home Health as an integral part of their delivery. Atrium is not. Mm-hmm. But Duke Home Health is. So while the waiver itself is not intended for home health, they can utilize home health agencies in that model based on those limited diagnoses, as you know. Yeah. So, and I think we're going to see hospital at home here to stay for a while. And the reason I say this is important for this group to understand from a serious illness standpoint. I serve on the State Health Coordinating Council, and you follow this data, the certificate of needs for hospitals, nursing homes, home health, and hospice. This came up in the acute care section of the SHIC, and how it's going to determine hospital needs for next year, and your diagnosis and your length of stays. And this is going to be a very tricky data collection standpoint for 2022. And it's going to come into play because I heard, his name's escaping me, the chief medical officer at Atrium Blue Ridge present how this is going to affect that in serious illness from their project. So we may see some juggling of CONs and everything just from the hospital at home issue on referrals, admissions in that arena, and length of stays. I don't mean to get in the periphery, but that does have a domino effect.
Yeah.
Bottom line, phenomenal project here. Unbelievable. We're here to help.
Yeah, Tim, let me just touch on hospital at home real quick, and then I see Ellie Ward and Linda. I'll get to both of you guys in a second. But Tim, to your hospital at home point, I do want to distinguish this project is not the hospital at home work, but with hospital at home, we are finalizing a learning collaborative opportunity for anyone to participate in, with Ariadne Labs serving as the technical assistance experts, where we're going to be doing 40 scrums, 2-week scrums, to iterate work products and workflows around scheduling, integration of home health, prescription, and then a regulatory symposium to consider CON, consider all of those pieces, because we're hearing from our health systems that that's immense. And so I will make sure that that information is shared. Your health systems, we did a survey to all across both North and South Carolina to get a sense of what people's pain points are with that. The regulatory piece came up over and over again. Duke's using their home health, Atrium isn't. UNC's using a hybrid. Cone's trying to figure out something different. And so bringing everybody together to figure out what would be an ideal use case in the Carolinas is part of it. And then after 18 months, so we're trying to launch that July 1 is when that home hospital work will really kick off for us with the Institute. And after about 18 months, so towards the end of next year, we're going to be bringing together folks and doing more of a summative evaluation of hospital at home in the Carolinas, looking at both the data and the outcomes. And then the other big piece right now is there is not a great way to track who is and who isn't a hospital at home patient in the EHR. And so CMS is asking for folks to figure that out. And so people are doing independent tracking and independent flagging, and how do they match them to the Medicare waiver? How do they match them to X? Because it's an inpatient diagnostic codes that they're using in order to get paid. So it's hard to create that balance. And so all of those things, thank you for bringing that up. We will be sharing an opportunity for everybody soon so that we can create that learning collaborative and let people participate and learn together and create these solutions. All of the solutions will be open source and available to implement for anybody. And so everything will be free, everything will be available. And that starts, we'll start recruiting participants in the late summer with hopes of kicking off our scrums around August and September. So just wanted to touch on that with hospital at home. Bringing it back to serious illness care, the short answer, Ellie, is yes, 100%. Rural and disenfranchised communities are a key component of what we do. So with the Institute, there are 4 areas of measurement that we really look at. They align really well with the quadruple aim. So it's really outcomes and disparities. But for us, it's critical that outcomes and disparities are linked. You cannot improve outcomes without addressing disparities, because you risk the potential of widening the disparity. And so that's a critical piece of it. And then the second side of this is the business case. How do we ensure that there's return on investment and patient and provider satisfaction? Special shout out to Laura Patel. She connected us with the wonderful folks at RAND. We've been having some great conversations with them about how we could use their new patient satisfaction and provider satisfaction tools and North Carolina to be a benchmarking state to really kick this work off and see how we could leverage some of this pilot work to test their new tools to really figure that out. But yeah, health inequities and health inequalities, particularly racial disparities, are critical. And there are things that we take very seriously and are looking at as we think about cancer, heart disease, dementias, renal disease, liver disease, et cetera. You know, for us, 100% Mark, dementia and Alzheimer's is one of our primary areas that I think we're leaning towards starting with, because to Karen's point about health inequities, in North Carolina in particular, while there is a incidence rate, a prevalence rate of almost 50% higher among Black and Hispanic patients. It is 2/3 underdiagnosed amongst them. And so that is a problem. And so how do we help address that? What are the ways we could potentially create a more holistic care model? Where are places we could do that? These are things we're trying to figure out. And we anticipate that topic action team will be helping us figure it out. We don't want to figure it out ourselves and tell you this is what we're doing. We want to do it with you. Linda, sorry.
Thank you. Yeah, and I'll quickly just share an observation and thought, and it sort of ties into the comments you were just making and some of the questions that have already been raised. I love the project, so excited, love this graphic as well. But when I look at this, it seems to me that the point of connection is a diagnosis or an acute healthcare kind of interaction. So it has the term of case manager identifying those support services needed. It starts with a diagnosis. I sit on, I chair our county's block grant advisory committee, and we have a collective impact age-friendly Forsyth County initiative going on. And one of the things that strikes me is how many people have serious illness, need all of this, but they're not at the point where they've had that diagnostic encounter.
Yeah.
Right? They're not starting at an acute episode. They're just out there struggling at home. And so I think when you look to define your population, if you can brainstorm about how do you find those folks before they even have that acute episode, that would be so helpful.
I hear that. I think that's the challenge. It's, where we're trying to figure out how do we balance, where do we start, and how do we then bring them in. And then the other piece of this, just to be fully transparent, is we're trying to do this with payer buy-in up front. And so that's where we're running into some of those, you can imagine. And so, but I agree. And hopefully as we think about our finance experts and we think about looking at costs of care, those patients and those families have an enormous cost to the system, but it's not being captured. And so what are the metrics we could potentially be looking at to capture that and share that story in a compelling way? I'm all ears. I think that's a great question.
And one of the things I'll just share and then turn it back to you is, it seems to me, we have a lot of people in our community who they're needing the meals delivered. They're tapping into the transportation services, and they're on the waiting list for home caregivers from the county.
Right.
I'll bet that's a great population to start with,
Yeah.
right? Because they probably have some serious illness issues. Yeah. So it's almost flipping it on its head and mining from the point of those social determinants of health.
Yeah.
To find the people that have slipped through the cracks.
No, that's a really, really good point. And I think that's something to consider. And what's important is we've got the entire spectrum, right? We've got this population that we'll design this program for. What I want to be very clear about the Institute is this isn't our serious illness care portfolio, right? This is a project this is our first project within serious illness care. And we need partners to say, but we need somebody thinking about this over here. And can you help? Like that's where we want to be. And that's where, like NC Care 360, all of those other opportunities. How do we bring those things together? Because there's stuff happening, but and people are doing this work. And how do we ensure that work, if it's doing amazing in Guilford, how do we then, or Forsyth or other counties in North Carolina, what is the environment that makes it successful in Forsyth? And then how would we then ensure that environment could be created in other parts of the state, in both states? And what also makes it a little bit interesting is we're working with South Carolina and others. And I think but these are the things, like, these are the questions that we love, because it's like, ooh, but then we can put this into our portfolio and figure out who are the partners that we bring to the table over here, because we have these resources to bring to bear. And we think this is a space where we can be supportive. we know we're in a discovery period and a cultivation period around 2 to 3 other areas as well, unrelated to serious illness, that we're going to be doing some research and hopefully able to share with partners in the next 6 months or so. We just brought on a new program design person to take on some more work because we think there's need. And so, but yeah, absolutely. And figuring out, to Deb's point, multiple diagnoses and they may have a primary diagnosis. It's not a serious illness, but the serious illness is the primary diagnosis, right? Even if it's secondary on their treatment protocol. So wholeheartedly agree. I know we're nearing 11, but I do want to make sure if there are other questions and other comments that we're able to get to those.
Jay, we've got until 11:15. So
okay, great. I'll speak just a little bit more to the payment piece. Allison, I see that you sent Ellie's question around rural and disenfranchised communities. I think we touched on that. That's a key component. We're looking at those disease states that I mentioned earlier and trying to map that based on our claims data so that we can see where they're occurring in the state. Rural Eastern North Carolina, Western North Carolina are definitely areas, the low country of South Carolina. The University of Michigan has a very, very interesting tool that they released. It's called the Multidimensional Index of Deep Disadvantage. It is a robust tool that's broken out by census tract that you can actually look in, and it overlays health data with poverty data and then socioeconomic information along with age, race, et cetera. And so it's been a place that we have used as just kind of identifying hotspots, not for any particular disease states, just hotspots in terms of where is their deep disadvantage. And then we can run our claims data on that particular census tract and see, okay, what are the claims that are coming up here? And it may be around serious illness, or maybe around our access to care or other opportunities that we look at. But regardless of this work, I highly encourage others to take a look at that piece of information. It's open source. It's available on the University of Michigan's website, but it's the Multidimensional Index of Deep Disadvantage, and it's a great resource and tool regardless of the type of healthcare work you're doing. Sue, great question. What specifically can the Serious Illness Coalition do to support the work? Actually, that's the question that David and I have had back and forth is how do you all see the best opportunities? And I'll be in the breakout with Laura and the clinical work group to really get a sense of who, where that care model, where there are ways that it's very similar to work that has been developed here. And so what are the ways that this group wants to stay informed in this work? We'll want to look to this group to figure out who would be the best fit for this topic action team. We're finalizing a charter for that and kind of a profile of person. So that'll be a place where this group, and we'll really lean on David and Catherine to get us those folks. And then that group, this is a really large and robust group that'll have a lot of importance and responsibility to this work, regardless of what we do. And so that smaller topic action team is going to be a little bit more nimble and kind of meeting at a high cadence to move this work forward. Linda? Oh, sorry. Oh, I thought you put your hand back up. Nope. Okay. Great. Great. And I will, it's always okay to end early. And I assume this is a lot to process. And so as you guys think about the work, please don't hesitate to reach out, email, chat offline. I'm happy to discuss further and open to being challenged on any of this and figuring out how we can do this better. I think it's a key piece of how we want to do this work. As we've been doing all of this work and kind of grounding ourselves in it with the Institute, for me, I kind of turn to reading and healthcare stuff, and what's important is how do we do this authentically. And there's a poem by, and I know you might not strike you as a person who reads a lot of poetry, but one of my favorite poets, it's a really interesting, odd guy, Philip Larkin, but he has a poem called The Mower. It's about a guy cutting his grass, and he runs over a hedgehog. But he ends it with, I think, some of my favorite lines that have kind of helped me through the pandemic, but has helped me ground this work. And I'll just share it with you and end it here, and then we can take a break before the breakouts. But the first day after death, the new absence is always the same. We should be careful of each other. We should be kind while there is still time. And for us, that's what we're trying to figure out with this population. While there's time, how do we ensure that we're careful and kind with them? So thank you guys. We're really excited to work with you and look forward to diving deeper in the breakouts.
Wonderful. Well, thank you so much, Jay and Madison, for sharing that and answering the questions. We will undoubtedly have more questions during the breakout sessions that will happen in a couple of minutes. So bring those together if you want to. And then Jay, are you going to stay with us?
I will be with us through the breakout session until noon, and then I'll have to hop off at noon. And then I believe Madison will have to hop off at 11:30, but we'll be here. But I'll be here until noon, and we'll see. So
right.
Yeah.
Great, thank you. And of course, we can email you, I would assume, at any point.
Yeah, I'll leave I'll put it in the chat, and then I'll even put my cell phone on there if you guys need to call. So
yeah, great. Oh, you know what? Mark Hensley had a question about dementia and Alzheimer's, an area that is near and dear to his heart. Mark, you want to just ask that again?
Mark, I think you're on mute.
He addressed that in his presentation.
Okay.
Yes, it was the #1 priority.
Yeah, it's near the top of our list. I think it's a space where, and kind of back to Linda's comment, I think where we've got to figure out there's a huge opportunity with that population to do it meaningfully. But then the other piece that we're running into is when we're thinking about a shared savings model, is there enough of a population identified for the risk to be able to be taken by both parties? And so balancing that is the key. The opportunity we have is, we've heard from our health systems specifically, they're going to be by 2023 with Medicare Advantage plans responsible for some percentage of downside risk. And so they want to get out ahead and figure out that population. So our health systems and our healthcare providers are very interested. We're figuring out how do we balance that with the timing of what population or what the risk pool needs to be for a payer to take. And so an opportunity we potentially see is for us as the Institute to act as a safety net for the providers and the payers so that there's enough capital at the table for them to take that risk. So just some things we're taking into consideration as we kind of design that opportunity. But that's near and dear to a space that I would love to work. But it is not my decision. Our topic action team will drive that decision.
Great. Thanks so much.
Mm-hmm. Oh, and then dementia, advanced care. Yeah, absolutely. Advanced care planning and advanced care directives will be critical in all of that. And also, a lot of the things that Shannon and Tim are working on down at the General Assembly, ensuring that legal documentation planning, estate planning, end of life planning, to the comment around racial disparities in this work, a huge missed opportunity, or an opportunity that is often not talked about, is how minority communities lose assets because they don't have proper end of life planning. And so the wealth leaks out of that community. Generational impact of providing good legal services of end of life for a family could have a tremendous downstream effect on minority populations in the state. And so how do we do that meaningfully? Where are the ways we could find funding and build that into a payment model that is critical? And so ensuring that people can preserve their assets and preserve their wealth so that their next generation has some place to start from is something that we've got to keep talking about and making sure it's relevant to this work.